Hey there, Gators, and welcome back for another lecture review in Psychology 200. So for this lecture, we're going to talk about psychological disorders. So we've got some learning outcomes that we're going to focus on. We're going to talk about abnormal behavior, models of abnormality, and then to get into some classifications and symptoms of different psychological disorders. I did want to start this lecture, though, with a really important caveat. So an important thing, I'm not a clinician. So if you read through and, we go through this lecture material and you're like, wow, I really think that I might have this disorder or one of my family members might, I'm not going to be able to diagnose you for that. I can offer resources, but I can't diagnose myself. Also, it's really important to realize that real people have each of these disorders that we'll talk about. So we want to be really careful not to increase stigma. So we don't want to, indicate disapproval or be, judgmental towards individuals. And we also really want to call people or use person-first language. Call them, a person first. So we wouldn't want to say, there's Bob, the schizophrenic. We would want to say, here's Bob, someone who suffers from schizophrenia. So he's not the schizophrenic. He's a whole individual who happens to have schizophrenia. So that's the person-first language idea. So just to get us in the mindset of what is normal versus abnormal behavior, I have a couple scenarios here that you can read. So we won't go through them necessarily, in this lecture review, but you can go ahead and read through and see what you think, and if you'd say this behavior was normal or abnormal. So we have 3 scenarios there. As you read through them, think why you would say this is normal or abnormal. So what are psychological disorders? So it's important to start with our definition. So when we're talking about psych disorders, we're talking about conditions that have these abnormal thoughts, feelings, and behaviors. So what does it mean to be abnormal? As you read through those earlier kind of vignettes about behaviors, you can see that you feel certain things are abnormal, and you can readily identify what you believe to be normal versus abnormal. But abnormal is really defined by one's culture. There's no specific universal definition of what is normal versus abnormal behavior. And many times this line is a matter of degree. So it's normal to wash our hands. I hope that everyone washes their hands. But it's not normal to wash our hands 50 times an hour. That is abnormal. So the same behavior, it's just a matter of times you engage in that behavior, or the type, the degree to which you engage in that behavior. So people who are really interested in psychological disorders, they'll study psychopathology. So this is the study of psych disorders. They look at the symptoms, how you treat them, where they develop from, the etiology, which is kind of how they develop, what are the risk factors, what causes these things to happen. So they really want to understand what's different about psych disorders versus behaviors that are just a little different or abnormal to us, situational, idiosyncratic, or unconventional. So it may not be conventional to dress up as an aardvark, and go to the grocery store dressed up as an aardvark. So that's something that we don't really see very often. It's unconventional, but it doesn't necessarily mean it's abnormal or it's not not typical, or that it's a psychological disorder. So it could be unusual or atypical, but not abnormal. That's the difference. It could be, unusual, atypical, but not abnormal. So we wouldn't call it a psychological disorder. So that's things like red hair. Red hair is unusual. We don't see a lot of people with red hair. It's atypical. It's not the typical color of hair, but it's not abnormal. So that's an important distinction. So what is abnormal then? So if we're kind of, muddying all these terms and trying to use them correctly, and we're saying abnormal is something different. So what does it mean to have a psychological disorder, to have abnormal behavior? What it means is that we've got a significant disturbance in our thoughts, our feelings, and our behaviors, and these disturbances are due to some kind of dysfunction. They lead us to feel distress or have a disability, and they don't reflect, expected or culturally approved behaviors. So we don't use terms like crazy, nuts, insane, psycho. These are not psychological terms. This is not something you'll ever hear in a psychology lecture like, here, let's talk about someone who's nuts now. We don't use those types of terms. Those are colloquial terms. They don't have meaning in psychology. So how do we tell then what is an abnormal behavior? So what psychologists rely on is the DSM. So we want to be able to diagnose individuals so that we can label symptoms, we know how to treat them, we know what we're all talking about. If we say somebody's experiencing depression, it's a common language. So for the United States, we'll use the DSM for this, the Diagnostic and Statistical Manual of Mental Disorders. It gives us the categories and the symptoms and everything we need. On the world basis, though, people use the ICD. So the ICD is the International Classification of Diseases. The World Health Organization is the one responsible for this. And they're both used in different ways. So the ICD is used throughout most other countries other than the U.S. It's often used for clinical diagnoses. The DSM is more used in research, but you would have a DSM diagnosis if you're here in the United States. So that's what the U.S. uses, is the DSM. DSM disorders, if we look at them across the lifespan, we see that there's a high prevalence of experiencing at least one disorder. Many people will not seek treatment for these disorders. We also see a high prevalence of comorbidity, so that's having 2 or more disorders co-occurring. And it's interesting because what is in the DSM is what we consider abnormal behavior. So that's the behavior that we consider abnormal. So until 1973, homosexuality was in the DSM, and it was an abnormal behavior then. It was a disorder. Once it's removed from the DSM, then psychologists no longer consider it abnormal or a disorder. So it just may be atypical, not the norm for everyone, but not a disorder. So what's in the DSM is really, really important. It dictates a lot of how we view behavior. We've got a lot of perspectives on psychological disorders. So a historical one was the supernatural perspective. This is things like, spirits are in your head that are controlling you and making you act in an abnormal way. Our biological perspectives are more, things we use today. So with that, it's that psychological disorders can be reduced to biological phenomena. And we do see that this is the case in many ways. So if we look at this graph below, we can see that, depending on the proportion of genes shared, really influences the likelihood that someone's going to experience schizophrenia. So the biological forces are important. There's another model that takes more into account biological and psychological processes. It's a very common model. It's the diathesis stress. So with this, we think that people have a diathesis, this underlying disposition or predisposition, that then is triggered when we experience some kind of stress or adverse event. So these are some perspectives on how psychological disorders actually develop. So now we'll talk about abnormal behavior and types of abnormal behavior by looking at these DSM categories for behavior. So we'll start with anxiety. Anxiety really is characterized by this, excessive, persistent feeling of anxiety. So this anxiety is disruptive. It's not in proportion to the actual threat. It's not mild anxiety. So everyone has experienced mild anxiety, and it may be good for us. If you've got, this feeling of anxiety about getting your paper in for class, and then you write it, and you get an A in history, that's a good thing then. That anxiety motivated you to do certain behaviors. When we're talking about an anxiety disorder, though, that's not where we're talking. So with this, we're talking more about this disruptive anxiety that has some of these symptoms you can see here, like wobbly legs and shaky feelings and senses of dread. This is really, really common, so many people experience anxiety disorders in their lifetime, more common in women. We'll talk about some specific types of anxiety disorders now. So some of these are phobias. So with a specific phobia, we're typically afraid of one kind of thing, one object, one behavior. So things like certain animals, getting a shot, afraid of clowns, afraid of flying. People with a phobia realize it's irrational, and they try to avoid that stimulus. So they don't want to get a shot, they don't want to fly on the airplane. And if they have to encounter it, it can cause a panic attack. So if you have a phobia of clowns and you happen to be in a haunted house and here pops out a clown, you can be triggered into a panic attack. So how we actually develop phobias is interesting. So many ways we think that phobias develop is through learning principles. So you might have been classically conditioned, make those associations with repeated pairing. So we saw that with little Albert being classically conditioned to fear a white rat. He had a phobia then towards white rats. You might learn it from watching other people. So if you see your mom scream every time she sees a clown, you might learn that. Or you might learn it verbally from being told something. My dad thought he was funny by telling me that you would get a shot with a square needle if you weren't good. And so it would be like an actual square tip, and they would have to jam it in there. So he just told me this. I never saw one because they don't exist, but I was sure that they did, and it made me very afraid of needles for a long time. So it was a verbal transmission. There's a lot of different types of phobias that you can review here. Another form of anxiety disorder is social anxiety disorder. So with this, people are very afraid of social situations and especially negative evaluation by other people. So they'll want to avoid social situations to not be evaluated negatively. If they can't avoid social situations, many times these individuals will engage in safety behaviors. So they'll do things like avoiding eye contact, talking briefly, wearing bland or neutral clothes so they don't stand out. The problem with this is that this usually exacerbates the problem then. So it makes them feel less willing to put themselves out there in the future. It makes them feel like nobody's paying attention to them, that they haven't made any good social contacts, they don't have any friends, because they're trying to avoid these situations so strongly. So it actually kind of perpetuates that anxiety to do these safety behaviors. So they're not really safety, they're more problematic. Another form of anxiety disorder is panic disorder. So many people will have a panic attack in their lifetime, and it doesn't mean they have panic disorder. With panic disorder, this is more when people have recurrent and unexpected panic attacks. So they might come out of nowhere. You might be doing your laundry and then bam, a panic attack. So a panic attack is a terrible feeling. It feels like you're going to die or lose control of your body. It's extreme anxiety, extreme fear. And so this is not a good feeling. So, sometimes then people will be so afraid of having a panic attack, having another one, that this will then trigger panic attacks. So it's almost like a fear of fear. So we think that this comes from, genetics, some issues with neurotransmitters and brain areas, as well as conditioning. We also think this can come from something called catastrophic cognitions. So sometimes people will, feel their breath tighten a little bit because they maybe walked up a flight of stairs, but then they'll trigger this feeling like, oh no, I'm going to have a panic attack. And then that catastrophic cognition, that fear, actually triggers the panic attack. So this can be almost like a cycle that people experience. Another form of anxiety disorder is generalized anxiety. So with this one, this is a very common form. People have this excessive, uncontrollable, and pointless worry. So it's not something that's tied into something that's really happening. It's just worry about routine, everyday things. And many times for people with generalized anxiety disorder, something will be removed from them that they don't have to worry about anymore. So maybe they're really worried about a test. They finish the test, but then something else immediately takes the place. So now they're worried about the weekend plans. Then they're worried about the washing machine. Then they're worried about the dog. So something is always taking the place. They're never not worried. Something, it's free-floating anxiety is what Freud called this. Very common. Females more likely to have it. And you can see this from a little, a young age. So Charlie Brown is someone who probably was diagnosable from generalized anxiety disorder. So you can see these worries come out with these little kids very, very early on. But you can develop generalized anxiety disorder anytime throughout the lifespan. All right, this brings us into our second category of disorders. So closely related, it's got this anxiety component, but it's its own category, are the obsessive compulsive and its related disorders. So obsessive compulsive disorder is one that we often hear in society, and we hear it used incorrectly. So being OCD does not mean that you just like to alphabetize your books. That's not what it means, or that you like to keep a clean house. Instead, it's intrusive, it's unpleasant, and you have to do these behaviors. You can't stop them. They're irrational. There's no point to them, and it's kind of, it's very difficult for the individuals who suffer from it. So it's about, a little over 2% of the U.S. will experience this in their lifetime. And what they experience then is a combination, most of the time a combination, of obsessions and compulsions. The obsessions are these thoughts that are unwanted. Things like, I'm covered in germs, doubting that you've turned your stove off, obsessing over order. And then the compulsions are behaviors that you feel like you have to do in some ways to minimize those obsessions. So, you have these fears of germs and dirt and you keep being obsessed with it, and then you have to wash your hands constantly. They don't always line up perfectly, so you can have compulsions that don't seem perfectly aligned to the obsessions, but it's just something that people really struggle with. And we think this comes from genetics as well as, we've seen some evidence for this hyperactive orbitofrontal cortex in people with OCD. So if you show them, messed up things, things that are out of line, out of order, pictures that are messed up, we can see this, this part of the brain really light up there. Body dysmorphic disorder is another one of the related disorders with OCD. With this, it's a preoccupation with some kind of perceived flaw. So many times other people don't even notice whatever it is this person thinks is so terrible, but they focus on some part of the body, often the skin, face, or hair, and think that it's really, really problematic or troublesome. So we see individuals then looking in mirrors, trying to hide the body part, and sometimes even engaging in cosmetic surgery. And finally, we have hoarding disorder that also falls under this OCD and related disorders category. So with this, people really struggle to get rid of personal possessions, even things that are completely useless, like garbage, literal garbage. They struggle to get rid of that. So it's some kind of control issue and real challenge making decisions between objects. So all of these are considered then OCD and related disorders. This brings us into PTSD. PTSD is really fascinating because it's the only one in the DSM that you have to have some kind of precipitating event for this to occur. So people with PTSD have had to have exposure to some kind of trauma. So this can be, we used to think it was mostly combat, but we see people who get this in response to natural disasters, terrorist attacks, sexual assaults, all kinds of different things can trigger PTSD. But we have to be exposed to or witness or really, really hear the details of a traumatic experience, and it has to involve real or threatened death, injury, or violence. So we have to have that predisposition, or this not a predisposition, but we have to have this precipitating event, some kind of trauma that then leads to PTSD. So for symptoms of PTSD, we see intrusive memories, flashbacks, just kind of reliving this whole experience, feeling like you're there again, avoiding. We see things like the exaggerated startle response, so we call this hypervigilance, but someone might just, come up behind them, and instead of just being like, oh, they might be like, oh, goodness, it's very exaggerated. It's a big startle response. And about 7% of the U.S. will experience this. We know that it's really important, what's going to help trigger PTSD is experiencing really severe trauma, as well as having fewer resources, so having fewer economic, intellectual, social support type resources, and then people with a history of adversity or family, mental illness in the family. And this brings us into the next category of mood disorders. For our mood disorders, what we've got is some kind of disturbance in our moods or our emotions. The two we'll talk about are depressive disorders and bipolar disorder. So depressive disorders mostly is depression is the main feature. Bipolar disorder is mania. So we'll talk about mania here in a minute. But our major depressive disorder is one of the most kind of common. We call it the common cold of psychiatric disorders. Very common in individuals to experience this. It has a lot of symptoms. So this graph down here will show a lot of these symptoms. Most people who experience a major depressive episode, it seems to come on as an episode, might last a few months. Most people are going to recover within a year, but for some people this will really persist. So treatment really is important. And we see this being more common among women. We've got a lot of risk factors for depression. So some are more genetic in their typology. Trying to think of my words there. But we can see things like neurotransmitter imbalance, cortisol problems. There's a lot of abnormal activity in the brain, as well as some social factors like unemployment and not having, strong interpersonal relationships. Stressful life events can cause this. So you can experience something stressful that triggers a depressive episode. And then the way we think can also trigger depressive episodes. So if we, call somebody and ask them out to dinner and they say, no, I'm just busy that day, and we think, oh, everybody hates me, they hate me, life is terrible, that is going to be a cognition that can then predispose one to depression. So it can be a mix of, social, personal, and genetic or biological factors. There are some specific subtypes of depression. So if you experience this largely in like the winter months, then we experience seasonal affective disorder or seasonal pattern. So this is during a particular time of the year. People can experience peripartum onset, which we often call postpartum depression. So it's during pregnancy or shortly after birth experiencing pregnancy symptom or depression symptoms. It's very, very common, so this is not something that is rare. Many women will experience baby blues, which is a mild form, or actually experience the depression. And then persistent depressive disorders, we used to call this dysthymia, and it's experienced depressed moods for a long period of time, longer than 2 years, but often not as intense as a major depressive episode. So that's the persistent depressive disorder. They're just kind of melancholy and just feel really low for years. Bipolar disorder is interesting. So it's different than our unipolar, which means one pole, unipolar, which is major depressive disorder in most cases. With bipolar, we're talking about two. Bipolar, so the depressive episode as well as the mania. So we're really getting this facilitation between depression and mania. In mania, this is something a lot of people are not familiar with. So mania actually looks like the person is euphoric. So you see someone who's really talkative, they've got flights of ideas, things are coming in their head over and over, new ideas. They're very grandiose with their thoughts. So I could, create the world's best internet site, even though I've never coded anything in my life. I'm sure I can do it. I'm going to quit my job. I'm going to do it. And so it's this, I can just do anything, these grand ideas. Many times they won't sleep and they'll engage in risky activities. When we talk about bipolar disorder, one major myth there is that people just keep shifting immediately within the day from sad to euphoric, from sad to euphoric, from sad to euphoric, and that's not the case. So we actually call it rapid cycling subtype when individuals have 4 or more manic depressive episodes within a year. So not even a day, a whole year. So this is not, bipolar disorder is not just shifting mood rapidly throughout the day. This is periods of depression followed by periods or chunks of mania. So that's a myth that we often hear. This will bring us into schizophrenia. Schizophrenia is what we call a psychotic disorder because many people can lose touch with reality when they suffer from schizophrenia. So it's a major disturbance they have in their thought, perceptions, emotions, and behaviors. It's very common for individuals with schizophrenia to need hospitalization, to have major impairments in their life. Not super common in prevalence-wise, but the main symptoms you'll see from individuals with schizophrenia are things like hallucinations, hearing things being the most common, delusions, which we'll look at, and then things like disorganized thinking and motor symptoms. So we'll look at some more symptoms of schizophrenia. But delusions, this is kind of thoughts that are abnormal, that are not in line with reality. So you can have paranoid delusions that people are coming to get you, grandiose delusions that you have some kind of special power, which this individual, here in this comic is saying the president's going to call me soon to help him. So you've got some kind of unique knowledge, or even somatic, that there's things happening to your body, there's cockroaches eating your liver, just things that are not happening, but you feel like they really and truly are. This graph will show some of the negative and positive symptoms in schizophrenia. So negative and positive do not mean like good and bad. What they mean is that negative are things that you kind of don't have as strongly as someone who is not experiencing schizophrenia, and positive are things that you have that most people who are psychologically healthy do not have. So negative, you're missing things that a psychologically healthy person would have. Positive, you've got things above and beyond what a normal person would have. So our negative symptoms include things like depression, alogia, which is poverty of speech, not talking very often, avolition, which is lack of motivated behavior, so you might drop the egg on the floor there and just leave it. The positive symptoms are additions to consciousness, and these are our hallucinations and delusions. So the risk of developing schizophrenia, we know this is really increased with genetics. So this graph here will show that if both parents have schizophrenia, your chance of having schizophrenia yourself is much higher. An identical twin as well. If you have an identical twin with schizophrenia, then your chance is much higher. So we know genetics plays a big role. There's also an idea that we have too much dopamine in certain areas of the brain, that there's enlarged ventricles have been shown in individuals with schizophrenia, which suggests brain tissue loss. Certain things can happen in pregnancy, so a big one is mother's exposure to the flu in that first trimester. If your mom is exposed to the flu in the first trimester, then you're more likely to have schizophrenia. So it's something we're really trying to understand, that immune response, so that we can kind of stop this from happening. But we know that it's a risk factor. We also see a risk factor for individuals who smoke marijuana. So they try to untangle this and make sure that we're just not seeing that individuals with schizophrenia smoke marijuana more often. But they don't believe that to be the case. They believe that marijuana use can actually, help cause schizophrenia. It's definitely not a guarantee, just a correlation. But overall, what we found is that there's some kind of genetic vulnerability that combines with the environment, and that's what's necessary for schizophrenia to develop. Brings us into our next category, which is dissociative disorders. So we've all had dissociative experiences. If you've ever driven somewhere and you think you're going to go to work, but then you show up at your friend's house and you're like, what am I doing here? You've just had this small disruption in your consciousness and you just kind of forgot what you were doing. But individuals can have this, constantly or in many different ways. And so this is where we end up with a dissociative disorder. So if you, trying to go to work, you end up at your boyfriend's house, that doesn't mean you have a disorder. For individuals where this happens frequently or to an extreme, so it's that matter of degree, then we can see more of a disorder. So these dissociative disorders are characterized by being split off or dissociated from the core sense of self. We're not sure on the estimates exactly. In many cases, these disorders are controversial. There's a couple that we'll talk about here. Dissociative amnesia. This is when individuals will just kind of forget who they are. So, much like you see on a soap opera where somebody wakes up and they have no memory of who they are, they just don't remember who they are, where they're supposed to be, or any of that personally relevant information. Usually this follows some sort of trauma or stress. Dissociative fugue is when individuals, kind of forget who they are, but then they wander, they travel. So they might not remember who they are and show up 4 states later living under some other identity, or wake up and they've been missing 2 weeks and they don't know where they've been. So it's just kind of this loss of identity for a while, and people will travel. And then depersonalization, derealization disorder. This is a form of dissociative identity or dissociative disorders where you feel detached from the self or from the world. So you just feel like the self isn't real, isn't really who you are, or the world itself isn't really there. It's something people really struggle to explain and really struggle to kind of deal with there. I've got a link here posted from a New York Times article from a woman who experienced this dissociative fugue. It's fascinating. One that you've probably heard of, though, the dissociative disorder you're probably familiar with, is what we used to call multiple personality disorder, but now we call this dissociative identity disorder. With individuals with DID, they have at least 2, oftentimes more, separate, distinct, and well-defined alters. So it's almost like having 2 or 3 people living within that one body or that one brain. And they can also experience memory gaps when another identity or alter was taking over at that time. This is something that's really controversial, so people are worried it can be used to avoid consequences. We also saw rates of disorder skyrocket after Sybil came out, which was a book and then a movie about someone with DID. But psychologists, this is in the DSM, psychologists believe that it is a legitimate disorder and a serious disorder. Not very common, but it's legitimate according to psychologists. And what we believe happens with dissociative identity disorder is many times that you've got someone who can't cope with something that they're experiencing. So oftentimes we're talking about a young child experiencing some form of abuse or trauma that's just too much for them psychologically. They can't cope with it. And so then in order to cope, they'll almost split or fragment their personality or their identity so that one part of the identity can deal with the trauma and stress and the other part can be, the child that doesn't have to experience that trauma and abuse. So it's almost like a defense mechanism or a form of coping to help to deal with trauma and stress. Herschel Walker is someone who's came out and said that he experienced dissociative identity disorder. So I've got a video linked in explaining where he comes from there. Our next category are personality disorders. So personality disorders seem, there's something that a lot of people are confused by because it is kind of saying that there's something about your personality that really deviates from what we expect as a culture and it causes distress and impairment. So it's something about who you are that really, makes it struggle for you to deal with others in a culturally appropriate manner. So, about 9% of the U.S. will experience this at some point in their life. There are 10 personality disorders in the DSM-5, so we won't go through all of these. We are going to spend a minute on antisocial and borderline personality, so those ones are highlighted here. So our borderline personality, this disorder is something that's hard for many people to conceptualize because it's pretty abstract. But what we're seeing with someone who's experiencing borderline personality disorder is this instability in relationships, self-image, and mood, and an extreme fear of abandonment and separation. So these individuals need others, their relationships form quickly, they're intense, they can engage in impulsive behaviors, reckless behaviors. If they feel like someone's leaving them, then they can be manipulative to keep that person there, engaging in things like self-harm. It's not a very common disorder. One really, really damaging thing with individuals with borderline personality disorder, though, is that 10% of them, approximately 10%, will commit suicide. So it doesn't mean attempt suicide. It actually means, commit suicide, which is very, very high, tremendously high, and something that's very concerning. So there's a lot of work to try to understand individuals with borderline personality disorder and really help them to kind of cope with this disorder. The other one we're going to talk about is antisocial personality disorder. So with this is where we get the terms more of psychopath, sociopath. So individuals with antisocial personality disorder, they really just don't have regard for other people's feelings. So they might hurt others, lie, manipulate, be really falsely charismatic to get their trust. But when they hurt someone, they really don't experience a lot of empathy or remorse. This doesn't mean that everyone with antisocial personality disorder is going to hurt somebody purposely. You know, they're not all murderers or anything like that. Many people live a, decent life and they do their best, but it is something that makes it, that lack of empathy can make it, where people might choose to commit crimes. So the B2K killer is one, Dennis Rader, who was very high in psychopathy, very antisocial personality. And the way he described committing murder was how we might describe going to the grocery store. And, like I might say, I picked up a head of lettuce, and he might say, I murdered somebody. It's just, he just doesn't have any empathy or sympathy for these individuals. So that's one of our personality disorders. And this brings us to our last category of disorders that we're going to talk about, and these are disorders in childhood, or what we call neurodevelopmental disorders. So there are several neurodevelopmental disorders. We're not going to spend our time talking about each of them, but we're going to talk about two. So the first one is attention deficit hyperactivity disorder, or what we refer to as ADHD. So with ADHD, this is something where we see this pattern of not being able to pay attention, being hyperactive, impulsive, difficulty following instructions, a messy workspace, forgetful. So this is diagnosed in childhood then, and we see these kids having a really hard time sitting down, a really hard time paying attention, a hard time completing tasks. It occurs in about 5% of kids, and we used to think that ADHD was something that just kind of happened as a kid and then you outgrew it. But recent evidence actually suggests that there can be lifelong consequences of ADHD, so it can lead to issues with achievement or with interpersonal relationships. So it's really important to help individuals with ADHD learn good coping skills early on. And then longitudinal studies really suggest it can be chronic. So adults who were, diagnosed with ADHD as children many times still meet criteria for that diagnosis and still struggle with some of those same characteristics and patterns. So my husband has ADHD, and he still struggles with lack of paying attention, doesn't follow directions, really struggles with attention to detail, forgetfulness. So he still has those experiences, as a 30-something-year-old man. We think that the issues with attention deficit disorder, or ADHD, are genetics. There's dopamine issues, so that's why things like stimulant medications work so well for these individuals, because it provides more dopamine and kind of gives them more of this stimulation that they're seeking. And then we also see some abnormalities in our frontal lobes. This will bring us to the last disorder that we'll talk about, which is autism spectrum. So individuals on the autism spectrum have significant disturbances in three main areas. So that's with social interaction, communication, and then we often see them have repetitive interests or behaviors. So the spectrum really indicates that it's a range of symptoms, so it's a continuum of symptoms, not just one thing, it's a whole spectrum. So these spectrums then, these behaviors vary in magnitude and severity. One common phrase that individuals in this field will say is, if you've met one person with autism spectrum disorder, you've met one person with autism spectrum disorder. So what they kind of mean by that is that there's no cookie cutter way of having ASD, that it's a very, very, individualized diagnosis. It's about 1 in 88 U.S. kids, more common in boys, and we really don't know what causes this. So we know it has genetic and environmental influences. There's been a lot of research into it, but we're just not sure exactly what's the case here. Scientists do believe, though, that vaccines are not the case, and your book gives, some description and information about that. If you haven't watched Sesame Street recently, they have a new character that's down there. That's Julia, and she's a character that's on the spectrum, and she's amazing. Well, that finally will finish us up for our psychological disorders unit. Thank you all.